Good afternoon, everybody. My name is Giampiero Leoncini. I am the representative of CAF Development Bank of Latin America in Trinidad and Tobago. It's a pleasure to welcome you to our second webinar on the questions around the coronavirus pandemic. So we last month we had a conversation on the problem of monitoring and surveillance of pandemics. And today we're going to deal with the issue of contact tracing. And we are delighted to have with us Professor George Rutherford, who is the Salvatore Pablo Lucia Professor of Epidemiology, Preventive Medicine, Pediatrics and History, and head of the Division of Infectious Disease and Global Epidemiology at the Department of Epidemiology and Biostatistics of the School of Medicine of the University of California, San Francisco. And also with us is Dr. Hannah Asman, Team Lead on Contact Tracing of UCSF, Senior Program Manager, Technical Advisor of the Caribbean Regional Program and Global Strategic Information in the University of California, San Francisco. So we're really, really grateful to have you with us and to having you make this presentation and have a conversation, discussion with the personnel of the Ministry of Health of Trinidad and Tobago. So CAF has been trying to help the country and the ministry in particular. In the last months, we approved an emergency health loan of $50 million for the ministry to cover the emergency expenses. And we are trying to bring this technical assistance also as part of our mandate to help the country in this complicated period. So I'm pleased that we are in this conversation with Mariam Richards, who is the Principal Medical Officer of the Ministry, and I would like to hand it over to her to say a few words before we begin.
Okay, hi, good afternoon, everyone. I'm presently at another meeting right now, but joining from my phone. Thank you very much to Gianpiero, the CAF representative for Trinidad and Tobago, as well as Dr. Rutherford, head of the EPI team at UCSF, and Dr. Asman, the team lead for the UCSF COVID response. Thus far in the parallel healthcare system, we've seen 1,141 persons either through confirmed cases of COVID, suspected cases of COVID, or under our state quarantine or state supervised quarantine facilities. This number is in effect from on or about March 12, 2022 to date. At present, we have 629 persons in quarantine in either state supervised quarantine or state quarantine as of today. And that's the largest number that we've ever had to deal with. We are really grateful to CAF for this support. CAF, of course, has been identified as a developmental ally, not just in providing financing for health, but technical cooperation and realizing linkages that we would not have usually had in health. They have, again, assisted us in acquiring the services of Doctors Rutherford and Asman for international expertise as per contact tracing. Contact tracing is essential given currently essential given that we have to reopen our borders at some point in the near future, and we need to really consider innovative measures with respect to contact tracing and reopening of the borders. We also have to consider the status of our healthcare workers, persons who would be in contact with persons that are being tested. And we've seen a lot of lessons in terms of contact tracing, especially in the last week or so when we let in over 600 persons in a 5-day period. So I would like to thank CAF and to the technical experts for their assistance and for demonstrating that health is an essential instrument of development and really helping us operationalize and improve our efforts. Thank you.
Well, great. It's Great. It's a real pleasure for Dr. Osman and I to be here with you today. We have projects. We've done most of our projects over the years with the Centers for Disease Control and the Caribbean Regional Epidemiology Consortium. We're currently working predominantly in Jamaica, but also work across the world, mostly on HIV in our group. When COVID started, our group at UCSF got dragged right into the middle of it, right on the first day, and have been consumed by all things COVID since then, including conducting large-scale epidemiologic studies, providing advice from everybody from the San Francisco Opera to the school district, and most importantly, helping the city and the state of California, the city of San Francisco and the state of California, with their contact tracing programs. So I'm going to start off and ask for the first slide, please. And we could get the full screen, possibly. Good. Perfect. So next slide, please. So these are what we're going to talk about today. We'll talk a little bit about fundamentals of contact tracing, and it sounds like you're pretty much on top of this already. Some of the informatics solutions that we've been using and have been proposed to us, how to mobilize a large workforce, a little bit about impact to date, and then some lessons learned. The next one, please. Next one, sorry. Go back one. I'm sorry. Just so you know, this is the University of California, San Francisco, right at the bottom of that green hill. This has an average temperature every day year round of about, what would you guess, Hannah? About 5 degrees centigrade. It gets the water. There's nothing between us and Siberia except the northern Pacific Ocean, and it is cold. So I envy you your tropical weather. The next one, please. So contact tracing is a time-honored component of communicable disease control. We don't talk a lot about history, but I think it's worthwhile to point out that contact tracing was probably first, put on the public health map in 1937 when it was proposed to be used for syphilis and also controlling syphilis around military bases. The idea with contact tracing is to communicate with those who have been diagnosed with infectious diseases, which I'll call cases, and to identify the persons to whom they've been exposed, who I'll call contacts, recommend strategies to reduce further transmission through isolation of the person who's infected and quarantine of people who have been exposed but are not yet infected. So we're catching them in the incubation period, presumably. So all these things lead to improved community and population health, and it's all about breaking the chain of transmission. But remember, isolation for infected and quarantine for exposed. The word quarantine, by the way, just to be slightly pedantic here, comes from the Latin for quarantus, which means 40, which was the number of days the Venetians made ships coming from the Near East lay at anchor before they could offload supplies and people. And that's basically boils down to twice the incubation period of plague. So that's what this is all about. The next one, please. So does science support contact tracing? There have been a million articles about this. I think this one is not so much for COVID, but for other things. This one is really good. In Shenzhen, which is a big go-go economy city near Hong Kong in southern China, their provincial CDC compared cases identified through symptom surveillance. That is, the cases that get reported in because people have symptoms and show up to get diagnosed, and contact tracing, and looking at times from symptom onset to confirmation, isolation, and admission. And as you can see that with contact tracing and isolation, we can decrease spread by decreasing the time during which cases are symptomatic and not isolated in the community. And this corresponds, in their estimations to a basic reproductive number, the number of cases that are caused by, they can be attributed to each primary case, of 0.4. So less than 1 is outstanding. 0.4 is exceptionally low. The next one, please. So when we're dealing with contact tracing, there's a huge issue of scale here. And in the United States, we were throwing around estimates of needing 300,000 people to do contact tracing. And you not only have to interview the cases, find the contacts and interview the contacts and get them tested, but then, as you know from having your 629 people in quarantine, you can't just tell me, okay, presto, you're in quarantine. You have to follow up with them. They need social support. They need food. They need a place to be. Their families need to be taken care of. It's not as simple as just snapping your finger and waving the quarantine wand over them. So, the way we built out our quarantine programs in San Francisco, and by the way, we're using currently about 150 people for contact tracing in San Francisco, which has a population of 880,000 and about 5,000 cases total. We're currently reporting about 25 cases a day. You need a digital solution because there's all of a sudden, this doesn't lend itself well to paper management when you're dealing with all these people. We have to mobilize human resources and we have to train them. The next one, please. So, how do we identify contacts? This is step one. Okay. First of all, case investigators need to interview people with COVID who've been diagnosed with COVID. They can come in because they've shown up and have gotten tested and test positive. Often it's because they're symptomatic and they're in the maybe in the hospital or maybe have been gone home, or they show up as contacts of cases that and turn out to be positive that way. So one of the things that we are very interested in when talking with cases is to try and figure out when we think they became infectious or contagious. And that's typically 2 days before symptom onset. If we have someone who's a contact and has no symptoms, then we'll, for instance, kind of arbitrarily assign a time frame of roughly 5 days before they present before we find them and identify them. We try and determine, as I said, when they became contagious and elicit the names and contact informations of persons they were in close contact with. Okay, now close contact is a really important consideration here, and we'll talk about that in a second. The next one, please. Okay, so who are close contacts? In China, 85% of the secondary cases were from household contacts. So household contacts are hugely important. The people you live with, you eat most of your meals with, those are your contacts. We also ask the cases about who they have been in close contact with, all right? And so there may be somebody who sits next to them at work. It may be someone they went out and had dinner with one night. It's not someone they passed in the market when they were both looking at cantaloupes at the same time, or whatever the melon you have. It's, you have to have prolonged contact. So, and we're especially interested if anyone who's been coughed on or has been sneezed on by a case, who's engaged in kissing. I think we can all just say kissing, sharing of food or eating utensils, or face-to-face contact for more than 10 minutes. And most of the workplace exposures, as I said, will be considered close contacts, desk-to-desk kind of things. Now, on the other hand, we need to be careful about whom we say is a close contact, because if you're a close contact, that means if you test negative, you're going into quarantine. And we would prefer to use quarantine somewhat more sparingly than was used, for instance, by the Chinese in the first SARS outbreak in 2003, when there were 20,000 people quarantined in Beijing, and they probably only needed to quarantine about 3,000, excuse me. The next one, please. So here's an idea about assessing this. So, so there's a lot about facial coverings and masks. And masks are hugely important, hugely important. So there was a non-outbreak that was reported yesterday from a medium-sized town in southern Missouri, which is right in the middle of the country, where a hair styling parlor went back into business, and one of the hairstylists had symptomatic disease, another had asymptomatic disease, and together they managed to expose 140 people in the space of 8 days. Okay, they had on masks, and the customers had on masks, and there were exactly 0 transmissions that were found, which I think is quite remarkable, and it really gives you an idea of how important masks are. So we differentiate in this grid about the cases and the contacts wearing facial coverings. Again, the case is more important because we're trying to cut down transmission from the case, but the contact's not unimportant. So if both the case and the contact are wearing facial coverings, and there has been more than 10 minutes of exposures, and they've been closer than 6 feet or 2 meters, we would consider that a low-risk contact and would monitor them by text messaging for 14 days. If one or the other is not wearing a mask, we consider that more of a medium risk, and we would recommend them for quarantine and for 14 days of SMS monitoring. I would probably be less inclined to put somebody in quarantine if the case were wearing a facial covering down here in this cell C, if those of you who are used to that terminology. I think that's far and away the more important. And then finally, high risk is when neither are wearing masks. They've been exposed for more than 10 minutes of face-to-face contact at less than 6 feet, and that clearly buys them quarantine. The next, please. All right, so some key definitions. What we're talking about here is when people are exposed but not sick. That is, they have not yet been confirmed as having infection, but they have been exposed. So they may well be incubating disease. And given that this has a fairly high transmission rate, I think we err on the side of quarantining people who we think have had significant exposures because we think they're going to get sick eventually. We also want them to stay separated from others and limit movement outside their home or other living environment. We tell them not to leave their homes for any non-urgent reasons. Don't go to work, school, or public areas, and avoid using public transportation, ride shares, or taxis. So these are the key definitions in quarantine. The next one, please. And for isolation, these are people who are known to be infected. They have confirmed disease. Sometimes they're symptomatic. Sometimes they're asymptomatic. We want them to stay home and leave only for medical care. In the home, anyone sick should separate themselves from others by staying in a specific sick bedroom or space, or using a different bathroom if possible. Now, I realize this gets quite complicated in lots of living situations. In San Francisco, because tourism has gone into the proverbial toilet, the health department has rented hotel rooms for people who are unable to isolate at home or who are homeless, for instance. And that's a way of getting them out of their living environment so the other people in their apartment or flat don't get infected. The next one, please. So just to summarize, quarantine guidelines is you must stay home and distance yourself from others for 14 days to see if you get sick. We may be backing down from that a little bit and might start using testing at around 12 days to cut people a break, but that's still up in the air. and it's 14 days from their last exposure to the person who's sick. And isolation is you need to stay away from others for at least 10 days after your symptoms have started until all your symptoms have gone away, plus 72 hours fever-free without medication. Early on, there was a lot of PCR testing to prove that people were no longer excreting virus, and that gets very complicated because some people have lots of broken up pieces of viruses in their noses, and you'll continue to find those, or even in stool, you'll continue to find those over time, and it becomes, people just get stuck forever. So we've gone more with this 10-day guideline. The next one, please. Okay. I think the other thing to mention, and this is something I've been harping on a lot, is when we have syphilis cases, we worry about people who have very high titers of syphilis, who are dark field positive, might be sex workers who are going to expose a lot of people and are very likely to transmit disease. There's this emerging construct in COVID that has to do with viral loads and people who have higher viral loads. The way we measure that, the way we approximate that, is when we do PCR testing, we count the number of cycles it takes for the machine to turn to find a positive. And the more you have to process something through PCR, which you amplify at each step with a cutoff at around 40. So if you need 38 or 39 cycles to find it, it means you have very, very tiny amount to start with. Whereas if you need 5 or 6 cycles to find it, it means you had a huge amount to start with, something like probably 10 to the 10th power of viral particles per milliliter of respiratory or nasal secretions. So if you know that somebody has a low cycle time and are highly infectious, those are somebody I would push to the top of the list to be interviewed. Similarly, if they worked in a congregate living facility like a skilled nursing facility or a nursing home or a jail or someplace where infection can spread very rapidly, I would also push them up to the top to get their contacts traced and isolated. Now, the contacts that need to be prioritized are those who work in congregate facilities like nursing homes, healthcare workers, and those who have older people in their households. And by older, I'm with the cutoff of 60 and all the guidance, that doesn't sound so old to me. So I think maybe 70. If you got your grandparents living with you, and they're all living and they're going to be exposed to this person who may be infected, I would push that contact to the top of the list as well. The next one, please. Okay, I'm going to turn it over to Hannah now. Take it away.
Hi, can you hear me now?
Yeah,
Great.
good.
Thanks, George. All right, here we go. So thanks, George, for that great lesson. I love the cordonniere snippet that you gave. So my goal for this over the next 10 to 15 minutes is to really give you a sense of how contact tracing is done within San Francisco. I think it started on at the end of March, really as a paper-based format, and we've since transitioned to using a digital platform, and I'll go into that in the next minute. So just as a quick overview, what exactly do contact traces do within San Francisco? We've divided this up into 3 buckets. One being communicating with contacts to notifying them of any exposures, of their potential exposure. We also provide disease and transmission information and collect information about their current living arrangements and daily activities to get a sense of, who else they may have been in contact with, or what are some of the risk of transmissions that could potentially occur. We also inquire about their medical status to ascertain any signs and symptoms of COVID, whether or not they have underlying medical conditions, and if there is a need for referrals for testing. And last but not least, as contact tracers, we provide recommendations about protocols or guidelines to maintain their health and the health of others. Also recommendations on following quarantine or isolation instructions and monitoring potential COVID-19 symptoms while they're in their monitoring period. As George had mentioned, we provide recommendations for referrals to other services as well, and that will be touched on a little bit later on down within this section as well. Okay, I think we covered this earlier, but here is a nice visual of questions that contact tracers do ask during an interview. One thing I wanted to highlight, because of the Bay Area and the demographic population, we do conduct interviews in various languages. We have a translation service available, and this has covered Spanish, I believe, Cantonese, Mandarin, as well as Tagalog, which is one of the Filipino languages, and Thai, as well as Russian. So we want to be inclusive and able to reach all populations within San Francisco, and this has worked out quite well. Okay. So previously I had mentioned that the information that contact tracers provide include recommendations, resources, referrals, as well as follow-up communication to assess for symptoms and well-being. I would like to emphasize that contacts are not told the identity of the person who may have exposed them. And we have had cases or instances really where contacts who are receiving a call from one of our tracers are curious as to who they were exposed from, but we are not at liberty to provide that. It is confidential, and usually this is received fine, and we proceed with the whole interview process. Okay. So I'm switching gears a little bit, and I'll talk a little about the relationship between the case investigation and the contact tracing. So you have a better sense of the overall or the holistic view of how this works. As George mentioned, we first identify a case through the system that is reported from the lab. And the case investigator is a separate team. Currently, it's a separate team who interviews persons who have been tested positive for COVID-19. These cases then identify persons they have been in close contact with and exposed to determine whether or not they are at risk of transmission. And this is also at the point where case investigators determine if they are contacts are close contacts, not so close contacts, and in what context or environment it happened, whether it's a household, social gathering, parties, it's summer now, so there's a lot of social gatherings happening, or if it was a workplace setting, as that helps to provide that information to the contact tracers and determine the sort of advice, recommendation that we would give. Then these contacts are then referred to contact tracers, which you'll see in the column on your right. And contact tracers then interview folks who have been in close contact with those tested positive, again, to assess their health status and provide recommendations for keeping themselves healthy and to prevent further transmission. Okay. This diagram pretty much shows how case investigators and contact tracers work together. It's pretty much a visual representation of what I just described in the previous slide. Okay, so what really happens during a shift? I think this diagram sort of tries to encapsulate that visually. We have a team lead or a supervisor that manages the shift for about 5 to 8 tracers, depending on the contact load or the assignment load. We also have a team clinician on standby who can be pulled in for support if there are any clinical questions that arise during an interview with a contact, or additional, guidelines in terms of if someone really needs to be seen immediately at a hospital or be sent via ambulance due to issues with any breathing, then that can also be conducted right away. In San Francisco itself, we work in shifts of 4-hour blocks. So for example, there is a shift that's currently ongoing, which started at 8 a.m. It lasts until 12 p.m. San Francisco time, with a team lead managing and supervising tracers. I believe today's tracers, we have about 7 tracers in the morning, since we've had about 25 cases with additional contacts that have been inputted overnight. Okay. In terms of contact tracing responsibilities, George talked about this a little bit in terms of prioritizing contacts. And here is another summary where we focus on folks who have symptoms, as well as folks who are considered high-risk individuals, including persons who are, again, 60 years or older, have pre-existing medical conditions, are immunocompromised, or are pregnant. We've also included, for San Francisco, folks who are homeless, or contacts who are homeless are also considered high-risk individuals as well. These contact tracing principles are really the foundation of public health practice, and it's incorporated into the work that we do. And that means that contact tracers are always practice confidentiality. This is what I had highlighted before in terms of information not being shared beyond public health officials, with a critical role in controlling the spread of COVID. Our sessions are all client-centered. We're very attuned to the contact's concerns, with the reminder that sessions and interviews are all voluntary. Everything is conducted without coercion. Our materials, our tools, our scripts are all evidence-based. We use the most latest and effective science to conduct our sessions or interviews. And last but not least, to be all-inclusive, we are culturally and linguistically appropriate to ensure that materials, information, referrals are accessible and available to all. Okay, so we've talked about goals and activities of contact tracing within the context of San Francisco itself. We've discussed, what are some of the questions that are covered, who is involved within a contact tracing team, as well as a case investigation. So then it comes to how this is really done. And earlier I had mentioned that we started off using paper-based forms, but as the numbers increased, we realized that was not sustainable at all. And since I think April 15th or April 8th, I'm blanking a bit, but either way, in COVID times, it was a million years ago, we've now partnered with, or SFDPH, the San Francisco Department of Public Health, has partnered with Damaji, which is an innovative technology company that's based in Cambridge in Massachusetts. Damaji has a platform called ComCare. It's open sourced, and so it's Python based, I believe. So it's pretty flexible in terms of what sort of components are needed per user. And for our purposes, we've housed our case investigation information and forms and data, as well as the contact tracing information, together with other public health actions within this ComCare field or ComCare platform with Damaji. So we work very closely with the developers. We're able to sort of run queries and reports very quickly and make changes as guideline changes how the workflow would change within a script, etc. And so this is a constant collaboration between UCSF, Damaji, as well as SFDPH. Okay. So apart from the technology, as well as the questions, then it really boils down to the team of addressing this this huge effort. It's been such a pleasure to see everybody really coming together and mobilizing a workforce to flatten the curve and to battle this pandemic. Particularly in San Francisco. And George will give us some numbers later on. But at the very beginning, in terms of anticipating this need, and with quick scratches on the back of the envelope, we had sort of made some quick calculations of who or what the sheer number of full-time staff that would be needed to quickly address, to support, track, and care for every case and contact fast and well. Some numbers that we've put up in the instance that there were about 40 cases per day, this could generate about 150 to 175 contacts per case. And that would require 9 full-time staff. If it was about 100 cases per day with 350 contacts elicited, that would require about 22 full-time staff. As we are encroaching the more relaxed or post-shelter in place with the opening of borders, more travel or non-essential travel potentially happening, the numbers, of course, will increase in terms of cases, or we anticipate an increase in terms of cases, as well as contacts, as well as full-time staff. And these are some quick numbers that we projected. And for San Francisco, as George mentioned, we have about 100, we would need about 100 to 150 people for a robust, sustainable workforce to address and reach the goal of eliminating or flattening the curve, really. Here is the current breakdown of training of SF's initial Army, and the Army is in quotes because it came up in one of the media coverages when this was first announced. It somehow has stuck, so I'll just leave it here for now. But we've had about more than 400 folks oriented to contact tracing. For those who have been trained in contact tracing, it's actually closer to 350. Sorry, this was just updated. And we've onboarded as active contact tracers about 141. And the breakdown includes UCSF staff, librarians, city attorneys, and other civil servants, including medical students from the University of California, San Francisco. Again, volunteer requests have been off the charts. We continuously get requests via email, phone calls for folks to volunteer. We haven't yet moved in that direction, but we're actively engaging with CD employees and UCSF staff for the time being. Okay. This again just provides an overview of the workflow for linking to testing and supportive services. The contact tracing interview really covers the events within the red boxes that you see, or the orange boxes, which then provides, after the screening, then provides the 14-day monitoring versus the support to stay in quarantine or isolation. And you'll see that there is a loop. If someone is then tested and is positive, it goes back up to being a case, and the loop continues with the contact and the demographics and the screening, etc. In terms of services, this has been mentioned by George, but San Francisco Department of Public Health is fully committed to facilitating isolation and quarantine, and we do provide wraparound services. It's comprehensive support that includes isolation and quarantine rooms in terms of hotels, so that folks can isolate or quarantine safely without exposing themselves further or spreading the transmission further. There's also food services that are provided, whether it's groceries that are delivered or meal preps that are ready to go. There's also resources in terms of cleaning supplies, and this can come in the form of hand sanitizers, bleach, soap, as well as in some instances, PPE or protective equipment. Medication support is also offered, whether it's the offer of delivering medication to folks who may not be able to leave their homes because they've been asked to quarantine or isolate, as well as support for other services like addiction or substance abuse. And the last piece is around income support. This has also been offered to folks who are not able to work because they have to safely quarantine and isolate, and we don't want to interrupt their process. And so some income support is also available to contacts as well. Okay. I'll pass it back to George to give us some numbers in terms of progress to date. So George, back to you.
Thanks, Hannah. Can I have the next slide, please?
Sure.
You were asked, should we have metrics? And so we're trying to back into 90, 90, 90, which should resonate with the HIV, with people who do HIV. So what we're trying to do is reach 90% of the cases and identify their contacts. We want to ensure that 90% of the cases that we reach can safely isolate. We want to reach at least 90% of all contacts identified. And we want to ensure that at least 90% of identified contacts can quarantine safely. So that's our 90, 90, 90. So it's 90% of cases interviewed, 90% of cases can safely isolate, 90% of contacts, which now makes 81%, right? Of contacts identified are reached and talked to, and 90% of those can get tested and go into quarantine. Next one, please. So this gives you an idea of how we're doing. There have been, I said 5,000. There have been about 3,000 cases in San Francisco to date, and 47 deaths. We're running at about 25 new cases a day. And since we've left shelter in place or are gradually leaving shelter in place, the number of contacts is going up. As Hannah showed before, it was around 3.5 per case, which are almost all household contacts. Now it's going to go up substantially, and we're guessing that it's going to go to 7. It may, in fact, go higher. The next one, please. This just shows you the day-to-day numbers of cases in San Francisco. Okay. The next one, please. So, all right. So we have an average number of cases of these are data that the state has suggested that we use as being able to move forward. So the average number of new cases per day is a combination of how many people are testing positive and confirmed as a new case for each day. So it's normalized to the population to allow comparison to other counties. So we're currently, the state's threshold is 2.5 cases per 100,000, and we're currently running at about 1.8 cases per 100,000. The next one, please. This is a testing rubric, and it's how many tests are done per day. We have a goal of testing an average of 1,800 people per day. That's a big goal. We're currently testing around 1,300 per day, The state has a threshold of 15 per 10,000. We've tried to make it more like 20 per 10,000, just to give you kind of round numbers. The next one, please. In terms of contact tracing, this is where we get into these rubrics. We're currently at 87% of cases reached for contact tracing interviews, which is slightly below the 90% goal. The next one, please. This is we've reached 85% of the contacts that have been named. And again, this is over the prior 2 weeks, which is kind of a rough period of time for when we're interviewing. I mean, we obviously are only interested from just physiologically from 2 days before they develop symptoms until the point in which they are isolated. But this gives you a kind of feel for going backwards a little bit more in time in case we're off. So we're reaching 85% of contacts. The next one, please. And so that brings us to what our lessons learned are. And if I may have the next one, please. I have never been to Port of Spain, and I've never been to Trinidad and Tobago, or Tobago, I'm sorry. Yes, you can tell by the way I mispronounced Tobago. It turns out that in San Francisco, this is really an interesting sociologic phenomenon, that this has settled into the Latin American community, which is not Mexican. It's really immigrant Central American community. And these are people who live in certain parts of San Francisco, a certain part of town, who work predominantly in essential industries, mostly things like construction, environmental services, those kinds of things. You get a lot move around on public transportation, and so these are the people who are getting sick, and because they're living in small apartments with either multiple family members, or in larger flats with multi-generational families, or in the case of single men living with lots of roommates, it's very tough for them to isolate. And we've seen this spread wildly through the population. While as in California, and this is true really throughout all of California, while people of Hispanic, whom we refer to these days as Latinx, and not differentiate between Latino, the masculine, and Latina, the feminine. About 43% of people in California are of Hispanic ethnicity. The 55% of the cases are in that population, and 68% of the deaths. The typical patient in the ICU is a 58, 62-year-old Latino man who has multiple underlying comorbidities, and that's a very typical patient. And you can see we don't really see any other hugely disproportionate things, except I should mention here that people of African ancestry, who constitute 6% of the California population, constitute 13% of all deaths. And what that's all about, we are still trying to piece together. And similarly, people of Native American ancestry who are living in California have a disproportionate number of deaths. There are horrendous outbreaks on Indian reservations and among the Indian nations, like Navajo Nation and the White Mountain Apache reservation as well. So this has been a major target for the U.S. A second lesson. So that's the first thing is know your demographics, and that's where you should be looking for cases. The next one, please. A second is don't get overly seduced by digital solutions. They do play a role, as Hannah has described. They can really help us, but there will be a million snake oil salesmen who come out of the woodwork who will try and sell you everything under the sun that basically will, if somebody's a case, it will paint their cell phone. Not paint is not in a literal sense, but will electronically paint their cell phone. So if you happen to wander by somebody, again on the cantaloupe aisle, your phone will start beeping. You won't know whose phone it is that is activating it, but you'll know that you're in close contact. There are lots of variations on that theme, but for a variety of reasons, not the least of which is not everybody has one of these phones. And for those of you who have one of these phones and try and explain it to your grandparents, you know how sort of tough that is. So I'm not wildly entranced with this. I think it might work well in certain situations, like on university campuses, but it's going to be tough sell otherwise. The next one, please. The third thing is that contact tracing is no silver bullet. And here you can see in Singapore, great, almost, no transmission. We're doing great. But then there's an introduction and it doubles overnight. So, stuff still happens. You have to stay on top of this. And you have to be able to quarantine people. This is what Hannah was talking about earlier about us using hotel rooms in San Francisco to put people up who cannot safely isolate and sometimes even quarantine. The next one, please. And then the fourth lesson is this is an opportunity to transform the public health system. We're somewhat strapped in that we're using repurposed civil servants, the librarians, the city attorneys, the people who work from the city assessor's office, who are absolutely terrific and have exactly the skill set that we want people to have. They can talk to people. They speak multiple languages. They have customer service, affects. That's all great. But they're going to have to go back to their regular jobs one day. And then with whom do we replace them? Okay. So, this is what Bill Gates says. The normal health service staff can't possibly do all the work, even if case numbers are fairly low. Every health system will have to figure out how to staff up so that this work is done in a timely fashion. Everyone who does the work have to be properly trained and required to keep all the information private. Researchers would be asked to study the database to find patterns of infection, again, with privacy safeguards in place. And to that end, we've started a training academy, a pop-up training academy. Again, this is all virtual, right? All virtual for the state of California to try and train people all over from all over the state. But at the end of the day, San Francisco is a very odd little place. It's probably 100 square kilometers. It's 49 square miles. I'm doing the translation in my head. It's 7 by 7 miles. It's got it has a relatively small population. It has a relatively large city budget for social services and healthcare, and it has very much a history of liberalism as well as dealing with epidemics. And if I could just have the last one, please. The whole point about trying to do pandemic control in San Francisco is that it's been done before, and it's been done before within my memory. I worked for the U.S. Centers for Disease Control and was assigned to the San Francisco Department of Public Health to set up the city's AIDS programs in the mid-1980s. So I've seen it all before here, and I know what's possible. And I know I have a good feel for what's worked and how to involve communities. So I think our lessons learned from HIV have been essentially instantly translated into COVID-19. And we're trying to get the right, we have the right mix of things, and we're trying to get those translated for other counties in California and for other places through CAF, through the CAF, to other places in the Americas. And we're delighted to be able to speak with you today. So with that, shall we do questions, Pablo? Or Hannah, anything else for you? Did you like to add?
No, I thought that was great. And we are very happy to answer any questions. Please do raise them if you have them, or you can also reach out to us separately.
So they're over in the live comments. We got lots of stuff here. Was there an equation?
I have one question.
Yeah, I see it.
From Bridget Smith. She said, good afternoon. She is the epidemiology officer in Tobago. Was there an equation for calculating your FTEs for contact tracing or number or contact tracers required per case?
Yep. So here's what it takes. Now, it's not based on population. It's really based on case counts. So for a case investigation, it takes about an hour. Okay, so that an FTE can do 8 of those a day, or probably fewer, actually. And then each contact takes about a half an hour. So you can do the math. So if you're running, say, 20 cases a day, just round, and I'm not sure, but round numbers, that means you need 20 hours of people to do case investigations. Those people will spin off, if it's 10, let's just say it's 5 for round numbers. Those people will spin off 100 contacts, each of whom takes a half an hour. And that'd be 50 hours worth of contact tracers. So that's like 6 or so, 6.5. So that gives you a feel for kind of the workforce you're talking about. Now, I would also add that not everybody is easily found, and we tend to set those aside and have a devoted service that deals with finding people that are harder to reach. That's where having the city attorney's office help. They have access to all sorts of other stuff that we in public health don't have access to, like tax bases and things like that. And they tend to be able to find people. Now, I will point out to everyone, just to say this again, this is all done virtually. This is all done by phone and text and email and occasionally a letter. In certain places where there may not be that kind of electronic density, you can do it the old-fashioned way and send people to the door and knock on the door and say, I got some good news and bad news. The good news is that we're going to be able to help you out through this. The bad news is you've been exposed. And I think that's especially if you have things to offer people, and income support, I will point out again, has been hugely important because it does allow somebody who's living as a day laborer and has family to take care of to not lose their apartment, to be able to safely go into quarantine, and to get off the street and out of the chain of transmission. Anna, do you have other things you'd like to add?
No, that was great. Thanks, George.
You don't have to say that.
Don't have more questions so far. Please just type your questions on the chat as Brigitte did. We can wait a couple of minutes, see if somebody has any questions. Do you want to add something, Hannah or George?
Somebody just jumped on here. I think that this is, if you're going to open up, right, which you want to do, this is something important to have. The other thing that you're going to need to think about is how are you going to screen people coming into the country? And that's going to be a complicated decision. I don't know if you know this, but New Zealand, which had basically achieved eradication, had 3 imported cases from Britain yesterday, from the United Kingdom. And so they caught those at the border. And I'm not sure how they did it, whether they were having to have everybody tested as they got off the plane, or it was probably much more likely that they did temperature checks. But then you can start to spin out the contact tracing from there. So border controls continue to be important in an island country, or a 2-island country, or a 2+ island country. I think you can, you're going to need to figure out about border controls. And I'm not sure how many people come into Port of Spain or into the country from airplanes versus ships. But it needs to be, you need to have something figured out about that. And I'm sure you do. But just to say that that's kind of a piece of this. The other thing that's a piece of this is as you figure out neighborhoods, and geography is hugely important here because people tend to transmit in small groups. As you figure out neighborhoods where infection is occurring, to have the ability to go in with a mobile van or some mobile testing thing, or to set up a tent and offer people testing to kind of a case finding sort of thing. That's also been, we've had a lot of good experience with that. And then you can explain it to lots of people at the same time. You can get the contact tracers there. You can do it all sort of in one fell swoop. There's a certain part of a city called Oakland, which is across the bay from San Francisco, where in a very narrow evidence, we ended up finding maybe 20% of the people were positive. So it's, I mean, you get those kinds of yields, which are hugely important, and you can do it on a Saturday and a Sunday, so it's not while people are going off to work. Gian Piero, any questions for you?
No, Professor, I think this was a brilliant presentation. I don't know, I know we have several of the key experts in the Ministry of Health who are following. I really want to motivate them to ask their questions now. Or maybe you were
you can email.
Clear.
Yeah, we explained everything perfectly, I'm sure. You can email me questions too, or Hannah as well. It's pretty easy. It's
also for the people who are following us in this streaming. We are in the same URL. You can find the video recorded at this webinar. You can share it with other people or officers at the Ministry of Health.
We have a question.
The Oakland model. Oakland's never modeled anything, by the way. That's not quite true. They had a wonderful baseball team for many years. There's not a real. I mean, the idea is that you set up. You set up essentially what amount to health fairs, and you can come in on. You advertise them. You come in over the weekend so that people aren't at work, and I mean, you don't have to do it at a health center necessarily. We've used public parks, church parking lots, but you basically set up stations where people can be interviewed and tested. You can do other things as well. You can do blood pressure checks. You can do diabetes checks if you want to. You do like urines or bloods for hyperglycemia. There are lots of things. It's really kind of up to you. But at least in terms of COVID, we're talking about getting swabs for PCR testing, and then you have to be able to find the people to get the results back to them, because while there are lateral flow assays that can give you the results in 15 minutes, you can only do one at a time on each machine. So it's not exactly practical, unless you're going to use it in an OR, to screen somebody before they go to surgery or something like that. It's just not. It's not a practical kind of disease control thing. So I would say that think back to health fairs that you may have had, and that's all we're talking about here. It's health fairs with testing, and have it advertised that way. And there should be a paper out this week, which I'm going to put Hannah on the case of finding it. And sending it to Gian Pietro for the first author is Diane Havler, Havlir. And this was actually a study, and it was done in San Francisco, not Oakland, but it's the idea about how do you do pop-up testing. And we call it pop-up because it goes into tents that we pop up, right? And that's the, it gives you, it'll have it described in it.
Yeah. I would also add that we're exploring models of working directly or partnering directly with community-based organizations to sort of reach certain populations or more vulnerable populations to increase access to these subpopulations within the city or within Oakland, for example. Since PBOs usually have a better sense of how and who to reach effectively. So that's still in the works, but that's another option or model that we're exploring at the moment.
And in case you missed that, CBOs is American for NGOs, for non-governmental organizations.
There's a lot of acronyms.
Okay, any more questions? I think that if there are no more questions at this point, well, I would just like to thank so much George and Hannah for this wonderful session. Really interesting, honestly, for me personally also. And I really hope this was beneficial. So we will keep the recording to share it with the ministry. And I think we will be able to share your presentation with them. Thank you so much. So we will do that also, and we will keep in touch. Hope we can do this also for other countries as well. It is we will be in touch.
Well, more importantly, we want to be able to visit all of you in Port of Spain one day soon.
Of course, we are looking forward to it. Okay, so thank you so much, and have a great afternoon, everybody.
Thanks a lot.
Thanks, everybody. It was a pleasure.
Bye-bye.
Bye.